The talk this evening is interscapular back pain as a window of metabolic diseases among patients visiting orthopedic clinics, and particularly patients visiting orthopedic clinic in my clinic at Nairobi Hospital. This study has been a study that has been my pet subject. It's a study that I've followed up over the years, and it's good to mention that this study is still going on to this moment. What I want to present are the data. What I want to present are the data of the patients that have been visiting my clinic that I've been able to question, and in looking at them, and I was able to question what was going on, and that's a result of those questioning that led to investigations, and some of those investigations are the ones that we are presenting this evening. But you'll notice that the majority of the patients that I'm presenting are young technocrats, people who are spending most of their time in front of a computer, and their mode of presentation was like some of them would come in and question that, why am I having problem with my upper back when I sit for long hours? And when they come asking that question, it's also intrigued me that I should be able to find out why people come and they say, I have to either stretch my back after I've sat for a long time before in front of a computer and I feel some discomfort. I want to emphasize that it has not been dramatic pain where somebody says, oh, I'm crying or pain, but they come questioning what is happening, why they feel tired, and they feel that they need to stretch the interscapular area after they have been sitting for long hours. And then that led me to, first of all, first physical examination, and of course, we did investigations and did tests that has revealed and has led to this informed presentation that I'm sharing with you this evening. There are series that I would say, a series of patients that I've looked after from, and the question came to my mind from 2013. But the ones I'm presenting are the ones that I looked after between 2013 and 2016. But we have a larger number now because I'm still going on looking after the patients that come in, and now most of them are on care during physiotherapy and treatments that were deemed necessary after the studies were carried out. I just want to make clear what I'm talking about, and if I want to just highlight particularly the area of interest is between this area here and the lower border of the scapula here around this area. Really, this is the area of interest where some of these patients presented with, and when they came to see us, then we were able to do physical examination, and led me after physical examination with local tenderness, particularly in that area. Then we found it necessary for us to look at it further, look at it a little bit more critically. We had x-rays, and after looking at the x-rays, then we decided to do assess their bone density. And again, just to emphasize again here, that these areas of interest, but one of the things I really would like us to appreciate is that if you look at this area, the symmetry of the scapula is one thing that we notice here. And particularly this patient, I'm highlighting it because this patient has very subtle scoliosis, and scoliosis is one of those confounding factors that brought a lot of challenge, particularly. And if you notice the scoliosis, then sometimes even if I don't find metabolic, then I understand why they are pain, because scoliosis is one of the confounding factors in the interscapular back pain. So you can see that this young man, much as we looked like, the back was symmetrical, straight for all we care, but when you do the x-ray, then it's obvious that the back is not quite straight. And although his BMD was normal, but when we found that he had this scoliosis, mild scoliosis, particularly the convex to the left side, and when we subjected them to treatment of scoliosis, the muscle balancing exercise, we were able to take care of their scoliosis. And as you notice that the majority of those patients that were fortunate to be able to see me, majority of them had bone density. And the bone density, commonly the mode of doing the bone density was by QCT bone density by bone mineral density done by a brilliance tomographic method. Now, that is a challenge because when you do brilliance tomographic method, you cannot do it on patients younger than 20 years. And generally, it's also the challenge. Of course, one of the things that I confess, the amount of radiation is quite a bit. But despite all that, the ones that were able to go through it, their findings were of interest, and that's what we will want to. That the 360 patients out of the 430 so patients, 360 of them, which is 87.7%, had some bone density issues and had either osteopenia or had frank osteoporosis. And the significant relationship was significant that indeed there was indeed a correlation between metabolic bone disease and the interscapular back pain. I want to emphasize here that the interest here is that this is a very early stage. If you can find osteopenia before it becomes frank osteoporosis, then of course there's every room to prevent it. You can be able to subject the mitral to physiotherapy, exercise, and modalities to prevent frank osteoporosis. And that need some of them actually were put on calcium, some of them were put on, looked at vitamin D3 levels, and some of them were even put on vitamin D3 and calcium supplement. The worst case scenario, some of them were put on bisphosphonates to be able to help them. But they are on a continuous care. They are able to look after their back. They understand their back. They are not, frankly, people who are already bending forward, people who are already losing height, people who are grossly osteoporotic. But they are that preventive stage when you can do everything to make sure that. And so that's the age spectrum. Between and the average age was 48. But there were some of them as young as 11. But I want to emphasize that the young ones, like that 11, we did the DEXA rather than the tomographic bone densitometry. And that's just the highlight. I mean, probably still there is that element that the women were more than men. The totals are highlighted there. And some of the results are here highlighted again. Again, this just shows us some of the results in the age groups. And at the end of it all, we can see that unless, of course, it's understandable that some of them could not do the bone density, some of them find the figures are different a little bit there because there's a cost element involved. The majority of them were paid by insurance, but where patients were paying themselves, of course, you could see that some of them would be challenged in getting their results. And that highlights some of the results of our finding and the analysis of the majority of the patients. Where normal here, and it's probably where I want to emphasize that scoliosis is one of the major confounding factors here. There are a few of them that had degenerative changes, but by and large, I would say the major confounding factor here was scoliosis because the scoliosis also presented in the scapular back pain, but in dorsal spine. And where we were able to find that there was scoliosis, then of course we treated the scoliosis, subjected them to physiotherapy. But I want to emphasize that that's one thing to look out for because you probably find quite a large number of those normal cases had scoliosis as a major confounding factor. And that's just again, just highlighting the frequency and again highlighting the number of patients that were found to have osteopenia. And that again just highlighted the analysis of metabolic bone issues that were found in some of these patients. Here, I want to emphasize that these were just case series. We have the next stage of this study, in my own estimation, will require controlled study, and we'll probably case control studies and do it in a prospective manner to see if we can be able to now do related to cause, so that we the causal relationship and look at the control group and do it over a period of time and be able to see whether we can prove our case and actually come out boldly and say that the case control side we are able to prove that the majority of these patients indeed we can be able to pick up. But as I say, the majority of these people are the people working in front of their computer, spending long hours, more than 8 hours in front of a computer. And then these results were able to reveal that, yes, there was a problem indeed that needed to be addressed. The findings have shown that a large majority of interscapular back pain visiting orthopedic clinic in Nairobi Israel were females, yes, indeed. And the females were above 50 years. And the patients had significant issues with their bone density. And one would wish to incorporate this interscapular back pain as part of the diagnostic approaches, or as part of the something to be considered as a way of preemptively making a diagnosis of metabolic bone disease. And we also, I think of note was that the majority of the patient had osteopenia, and which is in agreement with other studies, but this I emphasize because if I can find a metabolic bone disease at this early stage, then we can institute preventive methods. We can say that we do everything to make sure that this patient does not go into frank osteoporosis. And that is the joy, that's the thing that I would say is the emphasis that I think everybody, whatever people can be able to do, then you would be able to institute whatever care, and if need be, probably explain to the patient so the patient can own up their issues and have whatever they do, either physical fitness, regular physical fitness, if they want to take medication, but you want to prevent spillover of osteopenia into osteoporosis. The conclusion, the patients presented with interscapular back pain tend to have osteopenia, some of them osteoporosis. This provides a platform for preventive diagnostic approach for metabolic bone disease. Further studies need to be conducted to investigate the relationship between pain, interscapular pain, and metabolic disease. The study was unable to develop or to suggest checklist preventive diagnostic approaches for metabolic bone disease. There is, however, the need to collect more data on pain and other factors that may also be contributing to be able to establish this fact. We need to define the interscapular actions there. There's no data on this degree of pain, but pain is usually created with the visual analog. And if you can look at it from the visual analog point of view, this is like grade 4, 5 type of pain. It's not one of those severe type of pain that the patient will be running. And the majority of them did not need any painkillers, but they just needed to be instructed on their lifestyle and also to be able to guide them on what to do. And majority of them end up in physiotherapy, back care programs, and we're still following some of them. We didn't have to do anything more than just to be able to instruct them and to develop their program of fitness program that was able to help them prevent the development of frank osteoporosis. And that's the brief presentation. And I just want to say that, of course, we are still buffeting by the winds of chance. And as we seek and be able to analyze and question what we are doing, I believe there are many more things that we can find out. And this is something that I believe we, as orthopedic fraternity, we should all be conversant and look out for it and be able to advise our patients accordingly. Thank you very much.
Thank you, Prof, for the talk. Short and concise, clear and to the point. I think we open the floor now for any questions, and people get their thoughts. I wanted to maybe ask,
Yes.
do you think the risk factors for osteoporosis in this part of the world are any different from those farther away from the equator?
I think I would say yes and no. You know, probably ours is, I think if this computer syndrome didn't bring it out, we'd think that we are safe. But I think it's true that the risk factors are there just as much because, you know, if anything, our dietary habits and our lifestyle probably, you know, because some of these fellows probably, I mean, if I openly discuss with them their lifestyle, particularly people who are in alcohol, people who are in habits that are likely to weaken their bone. But I think we just have as much risk. They are probably the same elsewhere with what we have in the Western world. I don't think they are much different. It's just that we are not looking out to see them. They are the same. That's my view. I don't know, somebody else may have a different view.
No, I mean, that's an interesting window into this, because probably people of black skin living within the tropics have been thinking we are immune or safe from this. It looks like probably not, yeah?
No, we are not. We are not. I think that's the message that let's look out for it, because there is something that we can all work on together before we get our people to the stage when we are now dealing with with fractures, the femoral neck, and we're dealing with fractures like college fractures and all those things. Because this is a stage when we can prevent a lot of that if we take them out.
That is true, Prof. There is one question from Joseph Masharia. He's asking, do you think the osteopenia was because of the sedentary lifestyle?
Well, one of that's maybe true, because a majority of the patients, what our advice was to take an active life, and so that they can start maybe some fitness program, regular programs, because that it was like a wake-up call for all of them. And when we discussed with them, they were able to look up and wake up. Yes, there's a reality. There's a something I can do to prevent this. I think that a lot of them have developed and changed their lifestyle in that. So maybe they might have been sedentary. You know, some of the people work with their computer. They spend time there on computer at home, they're on computer in the office, and they just sitting glued in front of that computer. And at the end of it all, that's when now they develop this stiffness and issues in their back.
Okay, thanks, Prof. Do you think your results would have been any different if you compared the urban Kenyan and the rural Kenyan?
Probably yes and no, because you see, you know, the majority of the urban Kenyans, in quotes, probably you'd say if they were that different, you'd say their dietary habits would probably, these people are eating better, so they would say that metabolic health, they would have better diet to improve there, and as opposed to the people who are living in the urban areas whose diet, in my view, would probably stereotyped, and they probably don't vary their diet much. So if they have metabolic issue because dietary issue, they'll probably be just as exposed as much as this. But so I don't know. I'm not sure. I think that's something aspect we didn't look at here.
Okay. Yeah,
maybe
thank you.
Comment, because that has been doing this metabolic issue in some of the urban, in the rural areas. So I don't know if in the hearing maybe want to say something.
You said who has got the data from the rural areas?
He's doing something. He's doing some study up countries. I don't know if you might want to talk about that. Because he may but maybe if he's also in the audience, maybe he can say something. It would be nice to hear what he has to say.
Dr. Sitati, are you in the audience? Let me see if I can see. I'm not sure I can see him here.
No, I don't have him, but it would be nice to hear what his views would be.
Yeah, maybe one of these other. We could discuss it. There's a question here about your BMD. Is CT scan for BMD a routine test?
It is, yes. It is a 3D study, as opposed, so it gives volumetric as opposed to, the DEXA is aerial BMD, which is a 2D study, which is, for all intents, aerial BMD is not as accurate as volumetric BMD. But it's just that the radiation but it's probably the better option than the aerial BMD.
So that's what you would routinely. The CT scan is what you would do routinely when you want to analyze your BMD.
Yes. I would do that. It was a 3D and it is more accurate. It's a volumetric. Aerial BMD is really not very good.
Okay, Prof. I think there's one more question from Dr. Masharia. Was there any improvement of the symptoms with using medication, or do you think exercises are the mainstay of treatment?
Yes. Yeah, exercises. There are, of course, maybe in the analysis, I would probably highlight that there are people who are put on calcium and vitamin. Vitamin D3 deficiency was one common problem, and a lot of them ended up are now on routine vitamin D3. Not so much of calcium, but vitamin D3. So, I would not be able to analyze and tell you that this data just be purely because of exercises, but a lot of people who went through this program who have been reviewed are on vitamin D3 now, and they are taking routinely. So that's the factor. But there is indeed an improvement. I've seen a lot of their follow-up is still ongoing on. I'll probably give that data later on.
Yeah, thank you, Prof. I think one more question.
Yes.
Have you seen similar cases in pregnant women? And if so, any preventive measures, given the risk of transient osteoporosis in pregnancy?
Yeah, let's say I've looked up, pregnant women, you can't do a CT scan on them, so I don't, maybe there will be data, it would be interesting to ask the gynecologist, but But the pregnant women, obviously, you know, their matter is compounded because, you know, with the pregnancy, and knowing that, you know, one of my pet arguments is that these people, the fact that they displace their center of gravity of their head coming forward, that again creates a bending force on their interscapular area. That probably makes it more obvious. But, you know, with the pregnant women, the pregnancy itself displaces their center of gravity, so they are more forward and they're more backward. I don't know, maybe it's possible, but, you know, if you see the women who are pregnant, their center of gravity, their head probably is backwards, and maybe I don't know if they would get interscapular. They may not get interscapular pain because of the hyperlordotic position that they assume.
Okay, well, one more question.
Yes.
Any feature that you would use to differentiate this from rhomboid myofascial pain?
Well, that is probably just because you see what I do when I do physical examination. One of the criteria for this diagnosis, not only the complaint of the patient, but physical finding of local tenderness in the definitive area between T6 and T8. That's a very important part of the diagnostic. That I found, apart from their complaint, there was local tenderness at that particular area. So the myofascial usually is paraspinal, is not usually really. So the only thing that it may be confused with is scoliosis, because the scoliosis, when they have pain, is usually paraspinal, is not usually directly in the scapular area, on the spinal column. But indeed, yes, that's something to think about. The only thing is that we have not specifically addressed myofascial. Maybe that's something to think about, because I'm not sure what diagnostic approaches you do myofascial thing, unless you do the muscle enzymes and also look at the conduction, muscle conduction, nerve conduction studies to develop that, but I'm not sure. I haven't looked at it that way.
Okay, thank you, Prof. To the audience, are there any more questions? If there are none, we want to thank Prof for the presentation and for taking time to prepare these, and we hope to see the follow-up and the long-term results in future. We'll be inviting you to share those results with us.
Thank you very much. Thank you very much.